of course, thrilled to be invited to present during Prostate Cancer Awareness Month. And I think what makes it most exciting is that I'm a member of our community. And of course, our practice is local here in Thousand Oaks and all over Ventura County. And I've always enjoyed the times that you've invited me before. So what I'm going to talk to you today about is two different things. One is to provide an overview about the state of the art about prostate imaging and improved ways of prostate cancer detection to reduce the harms. And then at the end of that, I'm going to share our experience with a revolutionary form of focal therapy called Tulsa Pro. And then at the end of that, of course, if you have questions, I'm happy to do my best to answer them. And I realize that this is a very sophisticated audience, very knowledgeable, and I'll try to do my best to meet your expectations. For me, and I'm proud to say that the state of prostate imaging is strong. I will try to avoid getting too political. But we know a thing or two because we've seen a thing or two. Our program is one of the first programs in the country. We started prostate imaging back in 2009. I've been mentored by Jelle Barents in Holland and Peter Choike at the NIH. And since that time, we've now grown and we perform and interpret more prostate MRs a month than any group in the entire country, including all the academic centers. We're doing around 530 to 550 exams a month. And with RadNet support, we're on track to grow that. And we're anticipating shortly to be doing approximately 700 exams a month. So with that experience, it's been very helpful to allow us to grow our knowledge base. We read, I'm the primary reader for over 21 locations in Southern California, most of which are done on a 3T MRI. And, not to bore this group who already is aware of this, but for the new members, in 2018, 180,000 new prostate cancers were discovered. It's the second leading cancer for men. 29,000 men died. And what we talk about is that breast cancer and prostate cancer are really two sides of the same coin. Same number of men and women are diagnosed each year, and roughly the same number of men and women die of their diseases. But women have done a much better job of getting active and encouraging improvements in diagnostic studies and treatment, and men have been a little bit behind the curve. But with groups like yours, I'm confident that we will be catching up to the women. Of course, we know that 2.9 million men are living with prostate cancer. And what we were told in medical school is that more men will die with their prostate cancer than of it. And it's encouraging that the 5-year survival rate is very high. So let's just start with the basics. What's wrong with PSA? 85% of men with a cutoff of 4 don't have prostate cancer. And yet 15% of men with a PSA below 4 are diagnosed with cancer. And the PSA levels can fluctuate. So before prostate imaging, the standard management was if your PSA was over 3 or 4, the urologist would do what we call the old blind poke and hope. They would, under crude ultrasound guidance, stick 12 needles into the gland to try to find out if you had cancer. And the challenge with that is that we were doing so many biopsies, but we weren't finding a lot of cancer. So the problem with breast biopsy is that important cancers are missed. So here they fire the needle. Can you see my cursor? Here's the cancer is here and the needle is missed. Here they find a small grade 1 or low grade indolent cancer by chance and miss the lethal cancer. Or here they get the cancer, but the red donut over here is the higher grade. Well, Gleason, I'm in a grade group 3 or 4. So if you just have the pathology from this, you're going to have inaccurate treatment and inaccurate outcomes. So with standard breast biopsy, there is at least 1/3 of those tumors are undergraded when they compare the histology from the core biopsy with the final outcome from robotic prostatectomy. So the clinical problem is that we use Gleason score, now grade group scores, to determine aggressiveness. And the random trust biopsies are not very accurate. So using trust biopsies to calculate Gleason scores frequently resulted in inappropriate therapy. So with that as a foundation, our friends, the US Preventative Service Task Force, concluded that PSA screening doesn't work. And the task force focused on harms of finding low-grade cancers. And of course, what the urologists would frequently say is, oh, we found a cancer. We know prostate cancer could be multifocal. We don't know what we missed. Therefore, we should simply take your prostate out and put it in a jar and you'll be cured. So they were doing a lot of biopsies, but they weren't helping men with treatment optimization. So my thing is moving. So there were too many false positives, and men were reluctant to get screened, and they were reluctant to deal with the threat of prostate cancer. So how can we do better? Standard PSA is insensitive, but PSA screening used correctly is a lifesaver. And what we found in 2008 to 2014, when the guidelines were not to do PSA, is that the incidence of prostate cancer hasn't changed. The men were still getting their cancers. We just were not detecting them early. So we saw a big decrease in biopsies. We saw a big decrease in hospitals performing robotic surgeries. And we also found a lot more men presenting with advanced late-stage disease. So in 2017, the guidelines were changed. They now gave PSA screening a C rating, and the updated statement continues to stress risks of overtreatment. So they want to have a discussion with the men before they get a PSA about what to do with the information. The other challenge I have with the guidelines are they only want to screen men between 55 and 69. And for all men over 75, the grade is still considered a D. In other words, they're not recommending that. And we all know that men are living longer and better, and we don't want to support a cutoff that has an arbitrary age cutoff with it. You have to look at the relative health and activity of individual men. But the Europeans are much better at this than the Americans. And the European study showed a 31% mortality reduction with appropriate PSA screening. The trial showed a mortality reduction of 44%, but that came at a cost. So the challenge with the US guidelines and just using PSA alone didn't take into account the benefit of adding MRI. So we want to apply risk modifiers, which is to add MRI. We want to identify indolent disease. So those microfoci of Gleason 6 that are frequently found at random biopsy, we don't see. And that's a good thing because we don't want to act or treat on those tiny cancers anyway. And we need to develop better biomarkers. The PCA3 study was one of the first ones, but it's not very accurate, so we've developed better ones. And of course, I borrowed this slide from our common friend, Dr. Mark Schultz from PCRI, and PSA relapse, the fourth shade. If you look at this slide, life expectancy after relapse, prostate cancers, men tend to live a long time with their disease, even after they've recurred due to improvements with androgen blockade and chemotherapy, which is a good thing. But what we're trying to do together is to find the cancers and come up with curative techniques so we don't get recurrence. So why diagnostic MRI? You can't solve a problem if you can't see it. Before prostate MR, it was the only gland in the body that was being targeted with biopsies without direct imaging. We can do needle biopsies of the lung with CT scanning. Women get needle-directed biopsies of the breast under mammography. Colonoscopy can directly see a polyp and remove it. But the prostate, until MR came along, was still the only gland that was being biopsied in a blind fashion. So I don't know if everybody's seen what a prostate MR looks like. This is an axial T2 image of the prostate, and you can clearly see there's a big black spot here, which is a high-grade tumor. So we look at the anatomic images, and then we also look at functional images with diffusion imaging. And for people with a scientific background, diffusion is a measure of free water. And we know the body is composed of a lot of water molecules, H2O. And the concept is that aggressive cancers tend to have more cell density or cell packing. So there's more restriction of motion of the free water molecules. And we can measure that and quantitate that on MR. And we use that as a very predictive factor about tumor aggressiveness. And just a quick overview about the prostate gland, about the normal zonal anatomy, that the largest portion of the anatomy as men get older is the transition zone. And this is the portion of the gland that men get involved with BPH, that the stromal nodules in the transition zone frequently grow, and they act to compress the urethra, making it difficult to completely empty the bladder. This is the hardest area for us to identify tumors because of the heterogeneity of the gland appearance. The peripheral zone is the zone that's closest to the rectum. And this is the zone that the urologists tend to be pretty good at sampling. And it's also a zone that we're much more accurate in finding cancers. And then at the top of the gland is normal central zone architecture and the anterior fibromuscular stroma. So most of the cancers that we see occur in the peripheral zone, and about a third of them are in the transition zone. I know people had some concerns about what is Pi-rads. My good friend Yali Barents and the International Pi-rads Committee, of which we're part of, we're one of the only private practice groups invited to serve on that committee, wanted everybody around the world to speak the same language, so that when I read a prostate and describe the risk of cancer, and someone in Indiana or New York City or Paris reads a prostate MR, we can have similar language and we can do more useful data outcomes about what's the likelihood that this gland may have cancer. So with Pi-rads, we break the gland down into the peripheral zone, which has its own scoring, and the transition zone has a separate scoring system. So clearly we go from Pi-rads 1 to 5, and each step up increases the likelihood that the patient may have cancer. So a Pi-rads 4 lesion in the peripheral zone has a nodule of decreased signal against the normal white background. And the money shot to distinguish tumors in the peripheral zone is diffusion. So we need to see a reduced signal intensity on the diffusion coefficient map, and we need to see corresponding high signal on a high B-value diffusion. The only difference between a score of Pi-rads 4 or 5 is they're identical, but the Pi-rads 5 is a larger size. So by definition, any nodule greater than 15 millimeters in maximum diameter would be scored a 5. And that's the same for the scoring in the transition zone. In the transition zone, however, instead of diffusion being the money shot, it's the anatomic morphology or the T2 appearance of the lesion. So if we see a lenticular or a non-circumscribed nodule of decreased signal, that's suspicious. So if we see a nodule and there is reduced diffusion, we can upscore a 2 to a 3. And this is on the newest version of Pi-rads version 2.1. And if we see a Pi-rads 3 lesion that shows enhancement, we can upscore it to a 4. And the same over here on the peripheral zone, if we see a Pi-rads 3 lesion that enhances, we can upscore it from a 3 to a 4. So I know that's confusing, but we try to use these parameters accurately. And in our experience, Pi-rads 1 has a very low likelihood that the patient harbors clinically significant cancer. A Pi-rads 3 conveys a risk of about 15 to 20% of cancer. In our data, Pi-rads 4, we find cancer about 80 to 85% of the time. And in Pi-rads 5, we find cancer approximately 90% of the time. So to put that into perspective, when we recommend a woman to undergo a breast biopsy from a mammogram, we only find cancer 25 to 30% of the time. So we're doing a much better job of finding cancer with prostate MR than we are with almost any other strategy. So the image on the right side of the screen is a normal. You can see the high signal of the peripheral zone. This is the anterior horn. This is the capsule of the prostate gland. This is the rectum. You can see the neurovascular bundles beautifully displayed here. And this heterogeneity in the middle of the gland is the transition zone with the stromal nodules. So here's another patient, and does anybody see an abnormality? So when urologists typically perform a biopsy in their office, they put the ultrasound wand inside the rectum, and then through that is a needle guide, and it's a core needle that shoots out 2 centimeters. And there's a 3 millimeter dead space of the tip. So the urologists sample only the back third of the gland. This is an area that they usually don't hit because it's technically harder for them to go there. And this is a patient's tumor that was missed after 3 rounds of standard benign biopsies. So this is what we're trying to change and improve. Before anybody gets a biopsy, we think they should have an MR so that we could target and hopefully get the cancer, should it be there, on the first time. The urologists were reluctant to trust us with their patients. They didn't want to give up control. And I think it's for 2 reasons. One, in the 90s, some academic centers started to try to do prostate MR with spectroscopy. But when everybody else tried to replicate the results, our outcomes were like 50%. It was like flipping a coin. So the urologists didn't find any value in sending patients to MR. So now we have level 1 randomized clinical control evidence from both the PROMISE and PRECISION trials that prove the value of getting a prostate MR first. So in the PRECISION trial, it was an international trial. And the question was, would MR prior to the first biopsy prevent overdiagnosis by finding clinically significant cancers? So there were biopsy-naive men randomized into either the systemic truss arm with ultrasound or MR prior to biopsy. And the MR arm would only be biopsied if there was an MR lesion seen. So if the MR was negative, there was no biopsy. So there was poor control for what MR might have missed. But the outcomes were interesting. There was a 12% increase in clinically significant cancer in the men who were triaged with MR. And there was a 13% decrease in finding baby and significant cancers that would not need to be treated. The urologic arm used 3 times more needles, leading to more harms. So this, I think, is the key point, that there's a 3 to 5% complication rate with the standard 12-core ultrasound biopsy, and that would be bleeding and infection. Some of those complications are serious enough that require hospitalization. The other problem is if the urologists just use PSA or biomarkers to guide their biopsies, there's going to be a third of men who are being biopsied who don't have cancer at all and did not need the risk of having a biopsy. So MR can really help triage men. We can avoid men having biopsies simply because their PSA is up when we don't find any cancer, and we can direct the needles to ensure that we get an accurate Gleason score. The PROMISE trial was done in Europe, a pretty large trial, 576 men with a PSA of less than 15 with no prior biopsy. This was kind of brutal. They did a transperitoneal mapping biopsy first, and then they followed it up with a 12-core ultrasound-guided biopsy. So transperitoneal mapping is when they use 30 needles in the prostate to map it out, and obviously that has some side effects. They used a more rigorous definition of clinically significant cancer. They used a grade group 3 or Gleason score 4+3, or a core length of tumor of 6 millimeters. So when they saturated the gland with biopsies, they found 71% tumors of which 40% were what they call clinically significant. MRI had a sensitivity with their definition of finding clinically significant cancer, 93%, so better than transperineal. But also more importantly, the negative predictive value of MR is very high. In other words, if we don't see anything, 90% of the time we're accurate versus 74% of the accuracy of the standard biopsy. 27% of men had benign MRs, and out of that group, 17 men did have cancer, so there was an 11% false negative rate. But out of those men, most of them had low-grade disease. The standard biopsy missed a lot more cancers than the false negative MR, and 44 men had serious adverse outcomes, 8%. So the use of imaging before biopsy reduces 27% of men not needing biopsy, finding fewer clinically insignificant cancer. So if the urologists allowed us to direct their needles by MR, they would find 18% more clinically significant cancers. And it's interesting, London is now requiring all men to get an MR prior to their biopsy, and the MR has to be done within 30 days of the biopsy. So the challenge that we're having is that we don't want to let the perfect be the enemy of the good. So even though MR isn't perfect, it's really one of the best tools we have, and it's more sensitive and accurate than doing blind poke and hope. So we think it's the time to embrace magnetic imaging prior to men getting their first biopsy. And if you look at the Venn diagrams of how men end up getting an MR, if a patient has an elevated PSA and they get a biopsy and it's benign, the urologist will order an MR to find out what they missed. If the biopsy is positive, they'll order an MR to find out staging to see if they may have missed a more aggressive tumor. And then we also do it for recurrence. So there's 100% of men who are being considered for biopsy would have a benefit of getting an MR first. So where we're going with this is radiogenomics, which is the integration of liquid biomarkers, imaging tools, and cancer genetic profiling is now the future for precision care for prostate cancer. And this was the consensus statement at the International Prostate Meeting in Boston that I attended. I went to both the meetings in 2018 and 2019. This year, of course, is virtual. So now the question that many men have is, should you omit the standard 12-core biopsy? If you omit the standard 12-core, you may miss a few significant cancers, but you will reduce the finding of overdiagnosis of indolent cancers and having men get their prostates ripped out for no good reason. And since we know most prostate cancers tend to be slow growing, if we miss something and you still get PSA and physical exams and they return, if their PSA continues to grow, we may find it on next year's MR and direct it without any significant change of outcome or harm. But we need more data before we can recommend changing the paradigm. What does MR miss? So the positive predictive value, and this is the standard definition of clinically significant cancer. It's a tumor volume of 0.5 cc's of Gleason score 3+4 or greater. So if you do the math, that's a nodule of 10 by 8 by 10 millimeters. And our positive predictive value of that is over 85%. The negative predictive value of a Pi-rads 1 or 2, and excluding clinically significant cancer, is also very high at 88 to 89%. So there's another study with 59 men that had a mean PSA of 7, 25% never had a biopsy, 41% had a benign biopsy, and 72% of these biopsies had cancer. There were 112 areas of normal prostate that were biopsied, and they found 18% additional cancers. 9.8% of them were clinically significant. So again, more and more studies are showing the same thing, that MR's accuracy for true positivity and negative accuracy is roughly 90% for both. What I do at our center is MR-guided in-bore biopsy. So with that, we only fire the needle 3 or 4 times in an area that urologists may have challenge with. We don't sample the whole gland. And when we do our outcome audits, we're pretty good about finding the tumors and having concordance with surgical outcomes. So if we add MRI, we could triage men who would benefit from biopsy and reduce the number of benign biopsies. We find more clinically significant cancers. But here's the key. We can assign men to active surveillance with higher confidence. If we've mapped out the gland and we know we're not missing anything, and we know the tumor volume and we know the grade groups, then those men can be confident that active surveillance may be the best option for them. So then, of course, the question is, what does it cost? So a 4K score is roughly $400. An ExoDx urine test as a genomic marker is $800. At our site, a prostate MR with contrast is around $600 to $750. So the MR is cheaper and more sensitive and more accurate. So our strategy is to screen with PSA and physical exam, then get an MR. When we make our prostate reports, we always include a PSA density, which is a fantastic biomarker in its own right, and it's free. So the PSA density takes the PSA value and it's divided into the gland volume. And the reason this is important is many men in this audience may have had a PSA of 8, and the urologist would say your PSA is really high. And they would go through 2 or 3 rounds of biopsies and they would find nothing. Well, when you calculate the gland volume, frequently those men have prostatic enlargement and their gland volume would be 80 cc's. So that PSA density would be normal at 0.1. We don't like to do a lot of biopsies on men with normal PSA densities. The cutoff is a PSA density of 0.15. So we think that the biomarker should be useful for the in-between patients, people with the Pi-rads 3 that have a incidence of cancer of between 20 and 30% to help figure out would they benefit from biopsy. Where are we going in the future? So we want to get fast MR techniques and maybe avoid contrast. That's called a biparametric MR. We want to get improved diffusion sequences and spatial textural assessment, and I'm involved with some clinical trials on both of those. We want to have lower imaging costs and greater access. We need to establish a manogram and better educate men that they should not be more afraid of the test and the disease than avoiding it. We're also working with exciting new artificial intelligence programs to improve our diagnostic accuracy from where it is now at 89% and allow us to be more efficient in performing this. And now, of course, the role of focal therapy and genomics to tailor therapy for men who may have unexpected higher grade genetic markers. So active surveillance and the role of focal therapy. This was published in the Journal of Urology in 2019. They looked at a large number of men on active surveillance for a 17-year frame. Most of them were grade group 1. And the protocols for active surveillance, as you know, is to get a repeat biopsy every 2 or 3 years. The mean age was 62, and the treatment-free probability over time went down. A lot of men would progress on active surveillance and need definitive therapy. So when men progress on active surveillance, we should consider active focal therapy. There are several types of focal therapy. Laser ablation was one of the early ones where under MR guidance, a laser probe is inserted into the tumor and it's heated and you can do real-time thermal mapping. The problem with the laser is you can't treat the whole gland. You can only treat a small tumor volume. Cryotherapy or freezing the prostate gland, it was hard to obtain precision and there was frequently damage to the rectum and the neurovascular bundle. There was a physician who was promoting that in Ventura, and we would see more recurrences from men who had cryotherapy than we did in other forms of focal therapy. Of course, there's guided IMRT as a form of focal therapy, and then there's HIFU. So the initial HIFU was done by sonoblate or ablatherm. And that had the challenge is that it couldn't treat a gland bigger than 40 or 50 cc's. So many men needed to have a simple reduction prostatectomy to get the gland volume small enough so it could be treated. And there was frequent rectal wall and neurovascular bundle damage, and there was no direct thermal mapping. It was just done under ultrasound guidance. So we've been working with some of the early pioneers in the LA area on the sonoblate form of HIFU. And what we found is that there was frequently edema in the lateral muscles of the pelvic sidewall, that there was a lot of edema in the anterior rectal wall. But this is what it looks like. You see a donut sign as they ablated and suppressed any blood flow going to the tumor, but it comes at a cost. So now what I want to turn to is what I feel is a real game changer, which is the Tulsa Pro form of HIFU. And this was approved by the FDA last year for the ablation of prostate tissue. And why we feel this is revolutionary is that it's customizable, predictable, incision-free outpatient treatment of grade group 1 and grade group 2 and some grade group 3 tumors. It's done under real-time MR imaging. The heating source is placed through the urethra like a Foley catheter. And there are 10 ultrasound crystal elements here that can be controlled individually, both to cover the volume of the prostate, as well as to focus on the heating patterns. The transurethral applicator also is water cooled to protect the urethra from heating injury or stricture. So this device rotates and we can treat the entire gland. And we also have a endorectal cooling device to protect the anterior rectal wall from heating. So all of the harms of the standard focal therapy are obviated and solved with the elegant engineering of TULSA. It's a closed loop process with vigorous control software so that we can provide gentle and accurate ablation. So we all know that the neurovascular bundle comes from the S2 and S4 nerve roots, and it blankets the posterior aspect of the prostate gland between 7 and 5 o'clock. And we know where those are, and we can try to avoid it. So we know there are 200,000 new prostate cancers, 60% are in men older than 65, 10 million men are living with enlargement of the prostate, and there are 400,000 surgeries for BPH. So we can do this technique to treat both prostate enlargement with benign disease, and we can also do it to kill cancer. And of course, the side effects are urinary and rectal challenges as well as erectile dysfunction. But localized prostate cancer is the unmet need. For a high-risk disease, those patients would benefit from either surgery or combined radiation and androgen blockade. For the intermediate risk, you have all three options: surgery, radiation, oops, I'm sorry that it's jumping, radiation, surgery, or focal therapy. And for low risk on active surveillance, that many men don't need anything. But both radical treatments carry disability, and they're acceptable for men with life-threatening disease, but frequently are overtreated if you have lower intermediate disease. So just the way women demanded breast conservation surgery for breast cancer instead of a radical mastectomy, why do we have to take out the entire prostate gland if there's an 8mm tumor only in one lobe? So this offers an opportunity for less invasive, functional preserving therapies which don't preclude additional intervention if needed in the future. So we plan with real-time guidance, we ablate with directional thermal ultrasound, we control with real-time thermal looping, and what we've discovered is that we want to get the prostate tissue heated gently to 55 degrees Celsius. At this heat, we can ablate and kill the tissues in about 5 to 10 seconds, and we don't want to boil or vaporize the tissue. And we can do this efficiently and do the treatment in about 45 minutes of heating time. So this is what it looks like. There's a robotic arm attached to computer software. This is the urethral applicator with the heating elements. It's connected to our energy display system to deliver the energy. We have a control console in the MR console. And here's the disposables, the endorectal cooling device, and the urethral applicator. So we can do whole gland ablation. We can do hemigland ablation. We can do post-radiation treatment failure safely with focal therapy. We can do both targeted ablation of BPH and a tumor all at the same time. When possible, we can create a very accurate contour. We have precision of within 2 millimeters of where the heating elements stop killing tumors from killing them. So if possible, we can do a hockey stick gland contouring to spare the neurovascular bundles. We also can try to spare the ejaculatory ducts to allow men to still have wet ejaculations. And we can also simply treat the transition zone to reduce the gland volume and improve men with symptoms of prostatic hypertrophy and poor bladder emptying. So the key concept is our heating pattern. And what I want to do now is show you this video of how this works. So the urologist inserts the applicator. The tip is in the bladder. So we know that we're getting bladder urine flow. And then we map out, and you can see under real-time imaging, the heat mapping that we get. And you can see how precise the heat element is being given. And the different colors correlate with different heating temperatures. So obviously this is sped up a little bit. You can see what it is from real time, but this is a reasonable sized gland of about 50 cc's, and we can sweep around and kill the entire prostate gland of tumor in roughly 40 minutes. And we can hopefully maintain function and control of bowel, bladder, and erectile function. So when we're done with that, we remove the applicator. The urologist then inserts a Foley catheter, and we keep the man to recover them for about an hour or two, and they go home same day with just a Foley catheter. So we think that this is really revolutionary. And at the end of the procedure, we do a dynamic contrast enhanced scan to prove that there's no viable prostate tissue. This is what we call a donut sign or lack of perfusion. So we do this as a team. We have an anesthesiologist. This is done under general anesthesia. We have a urologist to safely introduce the applicator over a guide wire through the urethra with the tip in the bladder and insert the rectal device. And then the radiologist, who has experience with imaging, sets up the contouring and monitors the treatment plan during the whole time. So there's been something called the TACT trial, which was the clinical application. So we can do the whole gland, we can do recurrence, we can do palliation. And this started back in 2000. They looked at it, they would section the prostate after heating to ensure that what they were thinking was proven by the pathologist. The TACT trial was done with 15 sites around the world and got FDA approval in 2019. So there were 13 sites across Europe and Canada, and we were able to show significant PSA reduction. So in the initial trial, there were 115 men with low and intermediate risk. The ablation plan was whole gland with sparing of the urethra and sphincter. And the endpoints at 12 months was greater than 75% PSA reduction and looking at adverse effects. So the mix was 60% of the men had grade group 2 disease, 20% had grade group 1 disease greater than 3 cores, and a small number of men had low-grade grade group 1 disease. And most of them were Pi-rads 4 and 5 with a few Pi-rads 3s. So when we look at the pre-treatment, the median PSA was 6. At 12 months, the PSA went down to 0.5 with a PSA nadir of 0.34. So this was a clinically significant reduction of PSA of ablating the entire gland. When we look at the histologic response at 12 months, there were 15% of men had residual disease at 1 year. Some of that was clinically significant. Most of it was insignificant disease after 1 year. Most men showed no evidence of residual disease at 1 year. When you compare that to radiation treatment, at radiation, they had 28% of men having clinically significant tumor still present after 1 year, and they only were able to cure about 50% of the men. So we get 80% disease control proven by biopsy with residual disease. And for men who have residual disease, they can either be retreated if they need it, or they can have standard therapy if they wish to pursue that. But 77% of men were free of high-grade volume Gleason 1 or more disease at the end of 1 year, and now we have 24-month data showing the same thing. When we're looking at functional outcomes, 2.6% of people had moderate incontinence of 2 pads, but at the end of a year, 7% were wearing a security pad a day. Only 1 patient had significant incontinence. Regarding erectile dysfunction, 83% of men maintained erection sufficient for penetration. There was 0% severe erectile dysfunction, and a quarter of the men had grade 2, where medication was able to provide guidance. And regarding adverse effects, there were no rectal injuries or grade 4 adverse effects. All attributed serious side effects were extremely low. Infection was the most common, which was easily treated. Less than 1% had urinary retention, and less than 1% developed urethral stricture. And so in conclusion, with TULSA, there was whole gland ablation in 115 men with intermediate risk disease. This was very effective at reducing PSA and prostate volume with low rates of side effect and residual disease. PSA reduction was significant. Prostate gland volume was reduced by 91%. 2-year follow-up was associated with a high degree of safety and maintenance of quality of life. No men had rectal or bowel injury. 99% returned to baseline urinary continence. 83% of potent men maintained or returned to have sufficient erections. 7% of men needed additional information in 2 years who had intermediate risk. That's comparable to accepted rates of relapse after standard cancer treatments as defined by the PIVOT and PROTECT trial. So this represented the learning curve at 13 academic sites with early generation devices. We now have our 2nd generation device at our treatment site at West Hills Hospital. So we screen with T2MR. We do an immediate post-contrast enhanced image to show that the tissue has been ablated. The PSA at 1 month dropped to 0.3. Then when you scan over time, the gland slowly scars down and the PSA remains barely detectable. We covered urinary continence and we talked about quality of life. The interesting thing is when you compare this with Ablatherm, which is the transrectal device, we got, with TULSA, 90% gland reduction. They got 60% gland reduction. They had 1/3 of people having severe adverse effects of grade group 3, 7.8% with TULSA. And urethral strictures, a third of men had severe urethral strictures, 26% had urinary retention. With TULSA, again, significantly reduced likelihood of side effects. And then when we compare that to the literature of Tulsa Pro compared to surgical prostatectomy, radiation, or HIFU, this is probably a little high. A lot of the urologists I speak to say that their men after prostatectomy have perhaps a 20% incidence of erectile dysfunction. Urinary incontinence with surgery is very low. Urethral stricture, however, is higher at surgery and HIFU than it is with TULSA. And with radiation, of course, there's significant GI toxicity. They're trying to reduce that by means of using a hydrogel spacer to protect the anterior rectal wall from radiation damage. So if we look at the standard of care failures of treatment, this is from a chief of urology. For every 100 patients that he performs a radical prostatectomy, 20 will recur, 60 may not have needed it, and only 20 will benefit. So in properly selected patient groups, active surveillance accepts 20% progression to radical therapy at 2 years and 50% at 10 years. Radiation therapy accepts a 30% recurrence rates requiring further therapy. And prostatectomy also has an unfortunate rate of recurrence if they don't have clear margins. So the ablative therapy consensus, 20% retreatment rate of clinically significant disease, is very comparable or perhaps even better than the other standard forms of treatment. So just in summary, we have a customizable, predicted, incision-free technique that can be useful for men at intermediate risk disease or who progress on active surveillance. We will be the full urologic treatment training. We work with a team. Our inclusion criteria is we want men to have a 12-core biopsy plus a target. We want to make sure we can optimize the treatment and that we're not missing anything. Urologists are a vital portion of the team because they'll do the pre and post treatment management of the patient and assist in the planning with the radiologist. The radiologist will use their skills to ensure that it's done safely. Of course, with HIFU, this is not covered by insurance at this time. Men can access their HSA savings plan, pay cash, or get it financed. And the follow-up MR is included in the price. So we can also do men who failed radiation because we know that men with radiation usually can't get a second course of radiation. There's some preliminary work being done on surgery for those patients, but we know with the scarring and fibrosis from radiation, it's going to make surgery a little bit more challenging. So that concludes the formal portion of my talk, and I'm happy to open it up for any